Anyway, all right. Okay. You can please go ahead and can you project the disclosure slide, because I put it on the presentation this morning.
Sure. Give me a sec here. Okay, let's see.
Yeah.
Oh,
So, Mohamed, you are, where are you, in fact? Because you are between the internet and the real world. Where are you now?
Can you see me?
Yes, I can see you. We can see you.
Right. I'm trying actually to
all right, so here we go. Here is the promo. I mean the disclosure slide mode. Can you see that?
Yes. All right. Okay. And you're going to go through the slides, right? One after the other.
Absolutely.
Jerry, we don't know. You must share your screen because it's not shared, I think.
Is it not shared?
No.
All right, let's see. Share. Can you see it now?
Not me. It's bizarre.
I can see it. I can see the screen.
I can see it.
Okay, so y'all see the slide there, the disclaimer.
Yep.
All right, go ahead. Take it away, Mo.
All right. Okay, go ahead. I mean, you next slide, please.
Oh, okay. All right.
Yeah, you're
Now I
gonna
gotta switch over here.
deal with that.
And here we go.
All right, I can see you now, and you can see me, I guess.
All right, hold on. Switching over. All right, here's your title slide.
All right. So we go to the. I don't know. I cannot move the. I cannot move the slide. So anyway, gentlemen, good morning. This is our case number 5. So it's going to be on vestibular rehab. When and when not, protocols, home, physical therapy, occupational therapy, and the progress. So next slide, please. So essentially, vestibular rehab is a sensory motor recalibration of the vestibulo-ocular reflex, visual vestibulo-ocular reflex, and vestibular spinal reflex post either acute and or chronic vertigo, imbalance, spatial disorientation, motion intolerance, etc. That is interfering with safety and activities of daily living. And the goal is to do what we call vestibular compensation. Next slide, please. And mechanisms of vestibular compensation, we can discuss it in different ways, but the critical component really is the reciprocal inhibition between the two vestibular nuclei at the brainstem due to asymmetric input from the peripheral system. And it's an important question. Are we dealing with a total versus partial denervation? Next slide, please. This is courtesy of Dr. Mayank Dushya, who is really one of the top neurophysiologists, neuroscientists in the vestibular system in Scotland. And what we're looking at here is the normal organization between the two labyrinths and their connection to here, the medial vestibular nuclei. and each side is inhibiting the contralateral side, what's called reciprocal inhibition. And in this case, the left and right ears are feeding symmetrical input to the central vestibular system. Next slide. When one side, for the sake of discussion, and they did this on animals, so total denervation of the right side, you can see here that the reciprocal inhibition from that side, the right side, to the left side is decreased. And that what triggers the asymmetry and trigger the vestibulo-ocular, vestibular-spinal asymmetry, vertigo, imbalance, and so forth. And as we know, it takes anywhere between 5 to 6 weeks for that reciprocal inhibition to reestablish through the type 1, type 2 neurons on both sides. Next slide, please. Oh, there was a third slide. That's the third one. Even though now the peripheral system has become completely out of the picture, you can see the two vestibular nuclei are now communicating as if it's a symmetrical input, and then the nystagmus would disappear, the imbalance would disappear. And I said, it's important to remember that this process will take anywhere between 5 to 6 weeks, as long as there is no variability from other side to that balance. Next slide. So here is the case number 5. It's a 55-year-old healthy male with a 6 month status post-vestibular neuritis, typical with persistent postural imbalance, motion intolerance. The vertigo finished in about a week or so, especially when he is playing tennis or golf. No hydropic ear symptoms or migraine, hearing is normal. So stop here and say, what is next to Dr. Gianoli and Dr. Ionescu?
Well, for me, the first thing I think about in someone who has had a bad bout of vestibular neuritis and some motion problems afterwards is, has he been evaluated for BPPV, which is exceedingly common after vestibular neuritis. And then if you have ruled that out or treated that, then the next question is, why is he not compensating as well as we'd expect? Which there's a number of different possibilities there, including drugs. Is he still on some, vestibular suppressant medications that are preventing compensation? Is he having some sort of uh, anxiety or panic preventing him from exposing himself to activities where his vestibular compensation would be more appropriate? And then you have to ask yourself too, is there something going on the other side as well? Because as you know, some of these folks, they may have a bout of severe vestibular loss, but it may not be a unilateral process as well. And then I think the last thing that comes to my mind is there something from a central standpoint, brain-wise, that's preventing compensation?
That's perfectly fine. He takes meclizine every now and then, but none of the other factors you mentioned, Jerry. Eugene?
I have not very much to add after Gerard, but I think that maybe, except if on the other side there is now another minimal vestibular impairment, and more ancient with no evident clinical expression. So maybe this patient is now he have had a bilateral hyporeflexia, but I don't know. I don't have another idea when compared to what was already said by Gerard.
Any additional tests? Any additional?
Yeah.
Uh,
I've got something to add. You said any additional tests?
Give me a second, please.
Oh,
Give me
sure.
a
Sorry.
second.
I'll shut up.
Yeah. No. It's not that, but just so that my train of thought. That's so. Gene or Jerry, what other testing or what other investigations or even different treatments would you consider?
You want to go first, Eugene?
Hmm?
Did you perform an video head input test? There was a video head input test. Do you hear me now?
Yeah.
No.
Yes. Can you hear
Uh,
me?
yes, I can hear you. Did you perform a video head input test? The normal side was had a normal pattern, or
Yeah, I didn't see him initially, but the report that came was a positive head impulse test indicating right-sided vestibular loss. Yes,
and it was normal on the left side.
yes,
All the three semicircular canals.
yes. But they didn't do any caloric testing, by the way.
Okay.
Hey,
And the cervical vestibular evoked potential was normal.
He had audiometry and also vamp as well, and it was normal. Yes,
So was superior neuritis on the right side
yes,
initially.
yeah.
Okay.
Jerry,
And
Were you finished, Eugene?
yes,
yeah.
I would like to see. Did you, if the eventual spontaneous nystagmus was also present or not?
Which vestibular
Uh, no, if you observe with the video nystagmus Google, have you noted still an, spontaneous nystagmus?
Yeah, there was a little bit of a spontaneous nystagmus, right beating.
Right beating on the deficit. Where was the
Yes,
deficit?
yeah,
Yes. So it's
yeah.
a little bit weird. I would imagine to search something on the with a scanner or an MRI on the right side.
They
Why? Yes.
they did an MRI and was reported negative. I did not really see the images myself.
But what is weird that you have a spontaneous nystagmus beating to the impaired side and not to the left,
Uh, the
which was supposed to
spontaneous,
be the normal side.
yeah, the spontaneous nystagmus was beating to the right side. Yes.
So, all right. So I have to make a comment. Um, and
Yes.
you may be getting into this. I think you might have alluded to it a second there, Mohamed, but I was just under the impression that the diagnosis of vestibular neuritis was based on the fact that the patient showed objective loss of vestibular function. And it sounds like if they didn't do calorics and they didn't do VHIT, et cetera, and demonstrating some objective significant loss of function, it really brings the whole issue of vestibular neuritis into doubt. And as Eugene was discussing, I mean, most patients have a superior vestibular neuritis, but you got to, in my mind, to make that diagnosis, you have to show a deficit and
Right.
objectively. And it kind of sounds like we don't have that yet, since we don't even have calorics.
All right. So if we go to the next slide. as I said, the MRI was normal, bilateral caloric weakness greater on the left side, and had physical therapy for about 5 months and no change. Art, you wanted to say something, Art?
Yep. I would agree with Jerry, and it's so important and so useful to have caloric testing done. The initial attack, well, 6 weeks ago or whenever it was, it could have wiped out one side, could have destroyed one side. It might have partially destroyed one side. And as we know, compensating for a partial loss is much more difficult. It might be some fluctuation on the bad side. So it's good to have calorics to try and document if there's any function left. You talk to a pilot. If you turn an airplane engine off, that's not a problem. If you have a dysfunctional airplane engine and it's still fluctuating a little bit, that is much more difficult to cope with and compensate for. So if only for that reason, it's so useful to have caloric testing done.
Oh, absolutely. And there are two comments here. One from the electrophysiologic work that was done by Ducia and others as well, animal experiments. Partial labyrinthectomies don't do very well as total or partial with no residual activity. So that's number one. Number two, there are a lot of people now who actually do the V-hit and don't do the caloric test. And that to me is a little unusual for two reasons.
Agreed.
One, caloric is very important because actually it gives us a better idea about the low frequency on one side or
exactly. Yeah, exactly. It also helps determine, you do the calorics and ask the patient if they've ever felt, oh, this is the same as my acute attack. Then you know that they had an acute attack, probably peripheral. I mean, that's a bit of a caveat there, but probably peripheral in nature. So you know what you're dealing with now. Partial loss, total loss, whatever.
Yes. Jerry, you also said that it's important to do caloric testing as part of vestibular evaluation, and I agree with that. But I have no explanation why some institutions globally actually would now just do the V-hit and stop.
Well, I think in the U.S. it's economic. I think vestibular testing pays so poorly that, a lot of times the most you'll get is just bilateral cool calorics and no hot. I've seen that a lot, but which I think is not real. It's not complete. I don't think it's the most accurate way of looking at things. And but I think really in the U.S. it's economics more than anything. I don't know about other countries.
That's a shame because apparently this patient had a spontaneous nystagmus. A spontaneous nystagmus can fool you if you just do cool calorics. It can look like a response when it's really a spontaneous that you're just activating.
Yeah.
So it's a real shame to not do not do hot calorics.
Absolutely. Yeah.
All right. Next slide, please.
Uh-oh. Give me a sec.
Sure. All right. So his vestibular exam, me now doing vestibular exam with VNG monitoring, his eye movements are normal, no central eye movements. The response was a little decreased bilaterally, more so on the left side, and there was right post-head shake nystagmus. So to me, I kind of said, okay, well, let's do the cold or ice water calorics. So is there anything else you would do before you go to the ice water calorics? Or based on that, what would be the next step?
Well, certainly somebody with decreased bilateral, calorics. I mean, that's somebody I would want to see rotational studies on. both help confirm, do we really have bilateral loss? And it's also, as far as the extent of it, I think would be very helpful.
Okay. It was not done. And in my current practice, I don't have the heavy duty rotational test system, but yes, I agree with you. But if we look at the right caloric, eyes caloric, it reversed. The patient has right beating spontaneous nystagmus, as you can see at the top of the slide. And the right caloric is left beating, and the left caloric, this is eyes, is kind of the same as the spontaneous nystagmus.
Yeah, pretty crappy ice response.
Yeah. Oh, well, it's still right beating, but not as right at the spontaneous nystagmus. So we don't have a chair, or even, let's say, we're convinced it's a left vestibular neuronitis uncompensated. What's the next question?
Well, the next question is, why is it uncompensated, or why is it not compensating?
Yes.
Which, kind of goes into what I was talking about.
The list you mentioned.
Yeah, and among the most common is one is, so often these folks get placed on benzodiazepines chronically, and will certainly do it.
Didn't.
The second being, do they have not a fixed lesion, but a fluctuating lesion, like Art was talking about with a partial labyrinthectomy? You get some fluctuating function that prevents adequate central compensation.
Right.
And then, we mentioned about brain issues, which it doesn't sound like this guy's the case with a normal MRI, normal eye movements. And then the other is inadequate exposure to the appropriate movements due to things like anxiety and panic that some of these folks get. But that
would an anxiety and panic delay vestibular compensation?
Yeah, so I have I'll tell you an interesting story. I had one lady who at the age of 16 she developed a vestibular. I suspect it was probably a vestibular neuritis, and has had recurrent BPPV since then. But I'm seeing her 20 years later in her mid 30s. And she has not laid down flat since the age of 16.
Oh, yes.
Because of the severe fear of getting vertigo. And even after we treated her BPPV and got her all fixed, she still refused. So that's somebody who's not going to adequately compensate, because she's not going to put her through the positions and movements to compensate. So that's one of the ones I would think of. And those folks, I really think you need to do something to help with anxiety and panic. And I don't mean benzodiazepines. I mean things like SSRIs that won't affect vestibular compensation.
Yeah, but that's you mentioned that the other side could be also fluctuating, but he did not really exhibit anything on the right side, and so how do we determine at least the left ear is totally lost? Because I think that's what is important. We, from the animal experiment, incomplete or partial loss, and there is debate here how much partial loss we're talking about. It could be interfering with the process of vestibular compensation. So,
Mo, I think one of the issues that is important to point out is, even with a total absence of a caloric response and a total absence of an ice water caloric response, does not mean there's no vestibular function. And I mean, I know you know that, but I think it's important to point out that just because there's no response doesn't mean you have no vestibular function. It just means you can't measure it. And presumably, in this guy's case, still has a little something going on that's preventing the compensation.
Right. Okay.
There's obviously something going on both sides. There's still it's decreased function. The spinning attack he had 6 weeks ago was by definition a unilateral attack. Maybe they had another unilateral attack years and years ago, maybe even asymptomatic. And Joe Furman has outlined the concept of uncompensating and recompensating is much more difficult. So you have like your patient at the age of 16, Jerry, if they had another acute attack, they'd even be worse because you compensate for your initial attack. If you have another attack after that, you have to uncompensate and recompensate, even if it's ipsilateral. If it's contralateral, then you've got a problem with both sides. If it's ipsilateral, you still have to do this uncompensating. As I said, Joe Furman, in a fantastic lecture in Korea, outlined this. It's so important, and that could be one reason, right? Why are you just not getting better? Well, it could be an issue.
Yes, if you look, it should look to the both sides, and maybe to add that it's important to know what kind of physical therapy would perform, because when the physical therapists perform a re-education on for the VOR on the chair with different speeds, you can observe that the on the normal side, the diminution of the vestibular ocular response, and we can observe a modification and the reappearance of a vestibular response on the bad side, on the impaired side. So yes, we should think to a bilateral process, maybe ignored on the normal side, which is definitely not a real important on complete areflexia, vestibular areflexia. There is something which is occurs on the both sides, probably.
Yeah.
Are you asking me, Eugen?
Yes, I think that there is an impairment, but bilateral, and exactly what was already told by Gerard and Art.
Okay. So if we go to the next slide, in my mind, actually, I've been utilizing the prone caloric testing. And doing the prone caloric, you're maximally stimulating the horizontal semicircular canal in that regard, because in doing so, you're getting to know if that left ear is going to reverse the spontaneous nystagmus or abolish it. And if we look at the right side, the spontaneous nystagmus is at the top. Prone calorics, you can argue there's a couple of what looks like a left beating. Granted, it is not as persistent, but it definitely reversed the right beating, the spontaneous nystagmus. To me, in this case, there is a kind of a residual activities in that ear that are not, and when I talk to Mayak about this, they actually believe that total ablation is one of the prerequisites of adequate vestibular compensation. It's like when you have somebody with Meniere's disease that is struggling, and you say, okay, vestibular nerve resection is the final answer. So from that point of view, the test showed that there is still a fluctuating left activities that interfering with reaching a adequate and complete central compensation. Okay. So what is the treatment option? We can continue physical therapy. It's not going to work. We've been doing it for 6 months. Vestibular suppressants are not going to help. Can do vestibular nerve resection. Jerry, would you do vestibular nerve resection? On Eugene too. Would you do vestibular nerve section on this patient?
Well, I'll put it like this. I think it's among the options. Certainly it's a lot bigger and riskier procedure than doing something, like gent. The three options we always talk about with complete deafferentation is surgical labyrinthectomy, IT gentamicin, and vestibular nerve section.
Yes.
To be honest with you, it's been a very long time since I've done a vestibular nerve section on a patient or even recommended it. Generally preferring the other two. If someone's got loss of hearing on that side, I think a transmastoid labyrinthectomy is the gold standard. Now, if someone still has hearing and you want to deafferent them, I think gentamicin the way to go.
Yes, and I definitely would. This is what everybody would say. At least everybody like yourself. But some people may opt for vestibular nerve section with sparing hearing. What do you think about that?
Well, I don't think it's a wrong decision. I just think I personally, I would probably reserve it if the gentamicin was unsuccessful. Mainly because it's got a higher morbidity than with the gentamicin. I mean, really the only major risk with the gentamicin, well, there's two major risks. One is loss of hearing.
Yes.
Which you also have that risk with the vestibular nerve section.
Yes.
And the second is that it won't work. But if it doesn't work and you have preserved hearing, you haven't lost anything by doing it.
Yes. Yeah. And this is what I did. I used gentamicin a couple of times, and the patient actually reached very good compensation. And we continued the rehab, obviously, even after the gentamicin. And one of the things, we can go to the next slide. So in the interpretation and the treatment option, this is inadequate vestibular compensation due to, I would say, non-functioning residual vestibular function. And the patient opted, obviously, for a gentamicin perfusion. We asked him to play tennis using an automatic ball trainer, actually, for 3 weeks, improved significantly, had another injection, and continued to do very well after that.
What's your protocol for gentamicin perfusion?
I do 40 milligram per mil. No buffering. Patient lying down, half an hour, and see the patient a week or so later. Do the exam, look at the spontaneous nystagmus. Definitely disappearance of vestibular nystagmus here is a good measure. I don't recall if we did another ice water irrigation. And, the literature show that 1 or 2 injections of gentamicin is not highly associated with hearing loss. Now, there is a genetic test that we can do, the mitochondrial DNA analysis, and actually University Hospital here in Cleveland do it. It's out of pocket. I don't think it is paid by the insurance. But I did not do it in this patient. And patient is very happy, and that resolved his problem. I haven't seen him for some time now.
So you use as your endpoint just clinical resolution of symptoms.
And the resolution of the spontaneous nystagmus on exam, and also the vestibular spinal reflex. I remember sending him to pashography, and his pashography actually was pretty good by the end of the treatment. I agree with you that we should have done the chair test, but we only have a couple of chairs in Cleveland. Not many people are using chair testing, Jerry, as I'm sure you know.
You can always send them down to me, Mo.
Oh, sure. Absolutely.
In the
We'll
week,
give them a spin and send them back.
All right.
in the week after you see them, Mo, do you tell them to keep active? Say, look, I'm causing some damage. You've got to go and keep active. Come back and see me in a week, but go out and keep active before you come and see me. You assume they're going to have to rehabilitate themselves and compensate. Don't sit at home. Come, keep active.
Mm-hmm. You know, Jerry, I want to go back to the chair. Let's say that this patient did not compensate, and we do chair test. How would we use it to decide on the next step?
Sure. So I think what the chair does, the initial chair study leaves you a baseline to let you know where things are progressing. And, the follow-up chair helps you figure out, are they compensating or not? I probably wouldn't do them any sooner than 6 months later.
Mm-hmm. Yes.
But I find it's very helpful in making the distinction between, okay, is it just an issue of they're not compensating? Is there another problem? And are they progressing toward that goal? And if I see a chair study that looks like the gains have come up, I'm happy because it tells me they are getting central compensation. If their gains have not budged from the beginning, it tells me I need to go back to the drawing board and figure out what's going on.
I definitely agree with that, and total vestibular loss should show a little bit of phase or latency shift on the chair test, and that would be a very useful use of the chair test. All right. So that's the case. I'd like to. I still have a few slides to. Really, when do we have to think of vestibular rehabilitation therapy? I think, in my mind, objective diagnosis of central vestibular asymmetry due to unilateral or bilateral. I don't think we should just send anybody for vestibular rehabilitation without objective documentation. Or if there is a visual vestibular mismatch, like the motion sickness or the MDDS cases. I see a lot of patients that have non-specific dizziness, honestly. Sometimes even postural dizziness are sent to vestibular rehab now. I don't know if this is your experience, Jerry and Eugene.
Anyway, it's clear that to get the rehabilitation the efficacy of the rehabilitation, it's go along with the an unilateral or we may say even bilateral but stable vestibular functions. That this case you presented here. It's a very nice case, and you stabilize finally both vestibule, and you get your compensation, and the subject. And it's very funny because I prescribe to my patients to get to the to practice sports of rackets, tennis or ping pong or
Yes.
because it's a very the speed of the displacement is very important, and is very varied as motion, and I think that it's a very good idea to
Yes.
continue after the vestibular rehabilitation. But one thing I think that I don't respond it to your question, but I think finally that the patient, is my opinion, that he developed, in fact, not an neuritis, but on a kind of episode of bilateral vestibular vestibulopathy, progressive vestibulopathy. I think that that was maybe this is the explanation for all those bizarre responses, the spontaneous nystagmus on the right and deficit on the same side, and no other explanations. Maybe because, we guys, the bilateral vestibulopathy, we can diagnose this on the criteria of Barney Society, but we are not able to explain to the patient which actually developed a progressive form what was this. It was a neuritis, it was a hydrops, we don't know. And the patient will tell you that they have 3 or 4 episodes of neuritis. This is a challenging diagnosis, and personally, I think that maybe your patient had, in fact, an episode of bilateral vestibulopathy. Sorry.
Yeah. Yes, I mean, we always have to keep in mind bilateral vestibular hypofunction or deficit for sure. But if it is really active, well, we should see something on the exam. And I think that's why I emphasize importance of doing vestibular exam with video monitoring or recording. All right, next slide, Jerry, please. So when not, okay, we already discussed the first one, fluctuating peripheral lesion. Every time there is a shift in the vestibular end organ, it takes 4 to 6 weeks to compensate. So really vestibular therapy in the presence of fluctuating peripheral function is it's not productive, whether it's unilateral or bilateral disease. And with the unilateral, it is clear from animal experiments that near total may not do as well as total labyrinthectomies. And the prone supine caloric differences here can be actually very, very helpful. And finally, active Meniere's disease. I see a lot of patients with active Meniere's disease going through vestibular rehab and they're not getting better. And definitely tumor and drop attacks are not indication for vestibular rehabilitation.
I think one of the things I see too, as well as patients with active, fluctuating vestibular problems like Meniere's referred for vestibular rehab, which I think is a couple of problems. One, I think it's a contraindication for vestibular rehab therapy, but also too, I think it's a waste of resources and money.
Yes, absolutely.
That's a patient who will need vestibular rehab, but you need to stabilize them first. And I find there's a lot of physicians that will refer for vestibular rehab before the patient's been stabilized, and that's why you get this cycling back and forth. They've been through vestibular rehab 5 times and they're still not better, and it's because they've been inappropriately treated.
Yes, and I would go further and say, Jerry, that there are some physicians, especially in ENT, who would do full ENT exam and would make a diagnosis, benign position vertigo, vestibular rehab, if the hearing is normal. And that to me is an incomplete evaluation of these patients.
Agreed.
I think you have that on your next slide. Is that it? Yeah.
I don't know. I honestly, I don't understand neurologists and ENT, because those are most of even primary care physicians. They make the diagnosis of benign position vertigo without even examining the patient or doing Dix-Volpine. So we have to keep that in mind. So what are the protocols? Well, we know the CRP for benign position vertigo. Again, the vestibular exam is important to determine what canal or canals and what mechanism, cupulolithiasis or canalolithiasis. And the cupulolithiasis, we know that posterior canal, Alan Simon should be credited as the first one that introduced that procedure. And I use it also for the horizontal canal. And then there is the canalolithiasis, posterior canal. Epley did his maneuver successfully, and it's very popular. Others also for the horizontal canal, canalolithiasis. Lampert actually was the first to report his rotational thing, and there are other contributors in the field. So we know about benign positional vertigo, but the critical point is two critical points, actually. One, if it is a diagnosis, we cannot do it without doing the proper exam, which is the Dix-Hallpike exam. Number two, we cannot treat it unless we know which canals and the mechanism. So with the next slide, please. I keep saying this, I have been saying this for years, but still needs to be distributed widely. Benign paroxysmal positional vertigo is not a diagnosis. It's a symptom of many diagnoses that can affect the ear. People with vestibular neuronitis typically will develop benign positional vertigo. Many years patients would have benign positional vertigo. There is idiopathic benign positional vertigo due to the calcium homeostasis and so forth. So the underlying diagnosis should be determined, and for the proper medical treatment of these patients. And in my opinion, it's a legal obligation and responsibility of the physicians that examine these patients in the first place. Comments?
Well, I'm with you on that. Most, the way I always explain it to patients is, BPPV just simply means you've had damage to your utricle. It doesn't answer the question as to why the utricle was damaged. If they're fortunate, it's a single episode and then just canalith repositioning fixes the problem. But when someone has recurrent BPPV, it means they have recurrent utricular damage, and you pretty much have to figure out what's going on. And I tell the patients the BPPV is the smoke, but we're looking for the fire, is what we're looking for.
Yes, agreed. So you recall the guys, the case I present now 2 months with the guys, the patient with repetitive and untractable anterior superior semicircular canal, and finally, and with a little expression, but there was a superior semicircular canal which was plugged partially. So yes, we should search for the initial cause, whether it is about Meniere's disease or other or neuronitis, etc.
Eugene, in the United States, I don't know about France, but in the United States, BPPV is listed as a diagnosis.
Oh, yes, in France also.
So the label.
In fairness, that preceded us knowing as much as we do about why people get BPPV, and because that's a label that's from a long time ago.
Yes. It kind of withstand the test of time, I suppose. Anyway,
you don't have to go back a couple of slides, Mo, but I wanted to emphasize this idea of supine versus prone calorics. It is so helpful from the diagnostic and legal point of view. You have to know what you're dealing with, and not many people talk about that. So if you lie somebody down, you see a spontaneous. Is that a spontaneous, or is that some residual function? Flip them over. If you flip the spontaneous, then it is function. If you don't flip the spontaneous, then it is a spontaneous. So that it's so helpful to know what the heck you're dealing with, which is step one before you send, and like you said, before you send anybody for VRT.
Yes, that's a good point, Arch.
And also, there are some recent publication for Northern European authors. There are many people which have some nystagmus, positional nystagmus, but they are healthy. They are no problem, no vestibular problem, and this is the percentage of nystagmus when you put the patient in hang position and supine, etc. It's nearly 70%. It's enormous. So even in my department, I have 2 or 3 persons, normal persons with no vertigo antecedents or problems, and they have a nystagmus in the distal pike position. And that's why very much people confund, and they even didn't, they are not aware that spontaneous nystagmus or provoked nystagmus may exist, and they will put a diagnosis, as you tell us, of BPPV.
Eugene,
Yeah.
Eugene, there's no chance that these folks were out drinking some French wine the night before?
No. I know some of them, yes, but they are a much amount of guys with no wine.
Let me smell it. Let me smell your breath. Let me smell your breath.
Well, okay. Actually, there is a question here. Some patients, you do the exam and they scream and say, "Oh, I am so dizzy. That's my dizziness." And you don't see any nystagmus. What do you do?
Well, I would tend to treat them just because, our exams are not infallible, and I've certainly seen some folks where that exact situation has happened where they describe having vertigo, but I don't see much on the exam, and they've done well with cannula 3 positioning.
And after you did the maneuver, did the vertigo disappear?
Yeah, that's what I'm talking about. They had what I would suspect is, BPPV that just did not show up on the exam. But, and I also kind of wonder if some of those folks, again, that anxiety thing kicks in where they're anticipating it and it doesn't happen that particular time when you check them, but they have some otoliths in the posterior canal that you're wiping away with an Apley maneuver or what have you.
I would agree with that too. I'm a vestibular physical therapist, and so I hate not to say something, but yeah, I think that comment about the anxiety and even just lifestyle behaviors of patients and patterns. I appreciate you all are very keen on finding good diagnosis, and that does take time. But from a treatment standpoint, a lot of times these patients don't have the knowledge or the intuition or the motivation to move, and that really is hindering on their cervical spine, their ocular motor function. They get deconditioned very easily. So I think there could be some value for referral to physical therapy. Again, if we're not seeing progress, we are getting the referrals from those who aren't going into comprehensive evaluations, and we are going to use our tools to refer back out, within that 6 to 8 week period if they aren't compensating. But subjective reports are very high. If the dizziness handicap inventory, if you're getting scores up above 50, it's the anxiety and it's the psychological support that they might need. And I do find that we might be able to help in that regard.
Yes, I think your point is well taken. And the DHI really is more of a psychological, not physiologic scale for that matter. But truly when you put somebody down and they say, "I'm so spinning," if they say dizzy without the spinning, yes, that could be an anxiety and stuff like this. And as you said, if they don't get better, then we need to kind of move on and try to find out what's going on. But there are people who just keep doing rehab, not necessarily with vestibular therapists. I think the first case that we presented, somebody was being treated for benign positional vertigo for almost a year or so, ended up with a big, huge cerebellar tumor. So, and that's why as we go through the presentation, emphasizing the importance of the kind of medical team, physicians, therapists, and primary care physician, because it's important for the patients, to be honest with you.
Mo, I would kind of echo something Morgan just said. It's the whole concept of the anxiety and panic associated with vestibular disorders does require some, counseling, if you would. And, the physicians usually don't have enough time to be able to provide that adequately. And I know it's not the technical job description of the physical therapist, but let's face it, they're going to spend 2-3 hours a week with them for 6 weeks. They're in a position where they can have an impact on that.
Yeah, that's so important. In the Canadian system, we were able to spend time with the patient at the hospital setting, and they're so thankful. Oh, you believe me? There's something wrong with, yes, there's something wrong with you. We're not sure where. I believe everything you've told me. Now go out and try and keep active or go to physiotherapy. They are so grateful to be told that they're legitimized and also that there's where the problem is.
So Mo, we're kind of running over time. I know you got a couple other slides.
Yes. Okay. So we can the home therapy. We can if the patient is able to do home therapy, we give them vestibular rehab to help them. We can go to the next slide, and this is the handout that we give patients, and it's basically a VOR and a VSR and visual vestibular protocol. Next slide, please. Definitely, they need to continue, especially the bilaterals, with physical therapy and occupational therapy. Really increasing muscle mass and core strength is key element in maintaining balance and reducing falls. And I'm sorry, I don't remember the physical therapist that just spoke right now. What do you think of that, Morgan? I think, right?
Yes, Morgan.
Yes, Morgan. Well, this is very important because there are a lot of people who fall in because of vestibular problems, but also because of musculoskeletal issues.
Yeah.
Sure.
Are you there? Oh, here you are, Morgan.
Oh,
yeah.
hi.
So
yeah, and I would say, for the average person, maybe physical exercise looks different to everybody, but you consider any kind of orthopedic considerations, neck considerations, neuropathy. Yeah, it's a big component. And, if our somatosensory system is 1/3 of our balance, that's a huge chunk of opportunity.
Yes. Thank you.
I tell you, Mo, I think if anything, the job of preventing falls is probably one of the most important jobs, not just of the physical therapist, but also any physician taking care of a patient with dizziness. Yeah, we want to, first you want to exclude life-threatening problems like a big cerebellar tumor. But once that's been excluded, the next thing is prevention of falls, which is probably your next big risk for life.
Yes, agree.
And morbidity.
All right, next slide, please. So the take-home message, vestibular rehab therapy is an important component in vestibular medicine. And over the years, it really has not been emphasized until in the late, maybe last 5 to 10 years or so. And next slide. I think I put different modalities and options. Next. And the protocols, when and when not, are important to keep in mind for long-term positive results. Next. And then I know that I am a little bit emphasizing that the underlying vestibular disease disorder must be established for successful and timely treatment, and that requires the multidisciplinary approach. You need to work with the primary care, ENT, neurology, and physical and occupational therapy. Next slide, please. So thank you. Those are two books I recommend highly. One by Jerry Gianoli, and the other one is by me. I'm sorry, Jerry, I didn't. Obviously, the file that I sent you didn't have the next slide for Eugen talk. So you need to try to find it and display it, because I think it is important for people to know what's the next slide is.
Yeah, so next month, Eugene's going to be the case presenter, and he's got a case of when I believe the title you gave me was when it looks like Meniere's, but it's not.
Yes.
Oh,
Yes.
So that'll be interesting. Well,
I
thanks
hope so.
everybody for another wonderful discussion, and sorry about all the technical difficulties earlier. We'll try and
I'm sorry. I gotta
iron those out.
Figure out what happened on my side here. Sorry.
good.
All right. Good to see you all.
Thanks, everybody.
Thanks,
Okay.
Eugen.
Hi,
See you next
everybody.
month.
Bye-bye.
Bye.
Okay.